Hi, I'm Dr. Rifaey, and today I'm going to give a short talk on back and neck pain. I am an interventional pain physician, so I'm an anesthesiologist by training, and after my anesthesiology residency, I did a fellowship in interventional pain management. So here's the agenda of today's talk. I'll discuss the epidemiology a little bit, followed by the anatomy and some common back problems. We'll talk about some prevention and also some treatment options. So 85% of the population will experience back pain by the time they're 50 years old. It's the second most common reason for visits to physicians, and it's the leading cause of disability in Americans under age 45. Most of the time, back pain will resolve within 6 weeks, but it often reoccurs. And nationwide, the cost of low back pain per year is about $50 billion. So it's a popular myth that back pains are, caused by one specific event, a car accident. I bent down to pick up something heavy and I herniated a disc. But that's actually rarely the case. It's typically a series of small traumatic events over the course of one's life that lead to chronic back pain. So in terms of, factors that contribute to back pain, poor nutrition can play a role. It can contribute to osteoporosis, degenerative disc disease. Fitness, stress, posture, and body mechanics also factor in. In terms of physical fitness, we often talk about core strength when it comes to back pain. Having a strong core, strong abdominal muscles protects you, and weak abdominal muscles can cause pressure on the lower back. Poor flexibility can increase the pressure on the lower back. So some things that you can do to protect your back are to increase your fitness level, start slow, and you should aim for 30 minutes a day, most days of the week. This is a very busy world, and we all lead stressful lives, and unfortunately, stress can lead to pain. Stress can cause tension within our muscles, which can contribute to back and neck pain. So find ways to reduce stress in your lives. This is preventative for pain. And now I'll just talk to you a little bit about the anatomy. So when we talk about the spine, we talk about the cervical spine or the neck, the thoracic spine or the thorax, and the lumbar spine. So there are 7 vertebral bodies in the neck, 12 in the mid-back, and 5 in the lower back. In between each vertebral body is an intervertebral disc, which you see here. So this is the disc here, and there is a vertebra on top and a vertebra on the bottom. And in terms of the discs, and the vertebral bodies, they are kind of the load-bearing structures of the spine. The discs carry most of the weight in our spine. The other thing you see on this slide are facet joints here. So this is the joint between this inferior articular process and this superior articular process. So these stack up on top of each other and form joints on the left and the right at every level of the spine. And those are also weight-bearing joints, and they provide some flexibility. The facet joints contribute to about 20% of the range of motion of your spine in terms of rotation and flexion and extension. So this is a close-up of what the discs look like. So the outer part of the disc is called the annulosus fibrosus, and the inner part is the nucleus pulposus. So the inner part is kind of this soft, squishy substance, and the outer part is very tough and fibrous. You can get tears in the disc, so tears in the outer part, which can result in leakage of the nucleus pulposus, and that can be very irritating to the spinal nerves. So you can get irritation, like chemical inflammation, which ensues, and you can develop what's commonly called sciatica if we're talking about the lumbar spinal segment, and it's typically felt as pain going down the legs. And the reason it occurs is because, imagine you have a tear here, and some of this nucleus pulposus is is leaking out, and it irritates this nerve root, which then descends and supplies sensation down into the legs. Alternatively, you can sometimes have what's called a disc herniation. That does not involve a tear of the disc. It just involves, let me go back up a little bit, where part of this disc is protruding posteriorly or toward the canal, and that too can affect these spinal nerve roots. So the other structure that's in the back are muscles, obviously. They provide support, movement, and structure. So there are also several ligaments in the spinal canal. In the front of the vertebral bodies, there is a very long anterior longitudinal ligament. In the back, there is a posterior longitudinal ligament. There's ligaments between each of the spinous processes, which project backwards, and you can sometimes feel them in thin people. And ligaments connect bones, and they provide stability to the spine. And this is the spinal cord, which is encased in the spinal canal. So it's housed in these bones. So again, this is the vertebral body in the front. In the back, you've got a spinous process here. And on the side, you have these pedicles here and lamina here. And then there's a piece of bone that protrudes to the side, and that's called a transverse process. And that's at every level of the spine. So the nerves, these are called spinal nerves, and they exit at every level of the spine through an opening that's created through these bones that are stacked on top of each other. And that opening is called a foramen. So sometimes we'll say that a patient has foraminal stenosis. And what we mean by that is that there's narrowing in this opening that's putting some pressure on this nerve. So it's not necessarily, we commonly call them pinched nerves. It doesn't have to be pinched for a patient to experience pain related to that nerve. All it takes is slight narrowing, which can irritate that nerve, and you then have pain in the distribution of that nerve. So if it's in the neck, you may have pain that runs down your arm. If it's in the lower back, you may have pain that goes down your leg. And a very common cause of lower back pain is what we call, an acute sprain or strain, which is basically overuse or injury of the muscles, tendons, and ligaments of the lower back. So it can be related to repetitive activities, or if you're doing an activity that you rarely do, like you're moving and you're lifting a bunch of heavy boxes, that can cause an acute back sprain/strain. So symptoms can be immediate, or they can develop over the course of a day. It typically presents as a spasm and stiffness and pain. And generally, the treatment is, you may have heard the term RICE before, but basically it means rest, ice, and take anti-inflammatory medications. We don't really recommend compression for the back. But there is a caveat to this. Prolonged bed rest is actually counterproductive. So we don't recommend that, you rest more than a couple of days for injuries like this. Okay. And so I already talked about this, but basically this picture is showing two things. One is that there's a tear in the disc, and you do see this leakage of the nucleus pulposus, which can irritate. So they're showing the red area here is inflammation of this spinal nerve root. And then it can also herniate. And I already discussed that. So this can be, slow and can happen over time due to degenerative changes, or it can occur with a trauma. Like, I bent over and I picked something heavy, and now I have this severe pain that's going down my leg. Other symptoms related to irritation of these nerve roots can include things like numbness, tingling, and weakness in the distribution of that nerve. And in severe cases, patients can report bladder and bowel changes, or as I said, weakness in the lower extremities or arms, depending on which level we're talking about. There are certain symptoms that we consider more serious than others. So if you're having weakness in your arms or your legs, you're dropping things all of a sudden, you're experiencing, difficulty urinating, or, incontinence of your stool, that is an emergency. You should call your doctor right away. And if you're unable to get into your doctor, this is worth a visit to the emergency room, because unfortunately, some of these changes do require urgent surgery, because if left like this and it persists for a long time, the changes can become permanent. So this is just a picture of what we talked about earlier. This is a disc herniation here. You can see how it's affecting so when you look at these images, it's right and left or reverse. So this is actually affecting the left side. So you'd expect this patient to have pain in the left lower extremity as a result. And this is an MRI. So you can see that this patient has degenerative disc disease here. So these are the discs. In the black segments are the discs, and the gray are the bones in between. So you can see that this patient does have some flattening of this purple disc here, which is between the L5 and S1 vertebral bodies, and also a disc herniation here. So when we use the term sciatica, it's actually a little bit of a misnomer. The sciatic nerve is this very large nerve that runs down the back of the leg, and it supplies sensation to the back of the thigh and the entire leg below the knee. And the reason we call it sciatica is because it mimics the distribution of the sciatic nerve. But what it truly is affecting the lumbar nerve roots when we're talking about lower back problems as a cause of leg pain. So the correct term is lumbar radicular pain, but we do commonly call it sciatica. And it's due to, as I said, irritation of the lumbar nerve roots, and sometimes it's due to compression of the nerve roots, and that can be due to a disc herniation. It can be due to more severe pathologies like cancer, a tumor pressing on the nerves, or due to trauma. So this is a depiction of what we call spondylolisthesis, and it just means that the bones are no longer in alignment. So you can see the fronts of these bones are lined up, and then when you come here, you can see that there's a step off. So that's called a spondylolisthesis. Okay. When it becomes problematic is if it's unstable. So if I see this, what I'll order for my patients are x-rays with a patient leaning forward, bending forward, or flexing, and leaning backward or extending their spines. And what we're looking for is to see if there's any movement. If it is unstable, that's a time where I would have patients see a spine surgeon to discuss possible fusion. Because the concern is that it's going to get worse, and the worst case scenario is that it gets worse acutely. So in terms of the general management, your physician will likely refer you to physical therapy, may put you on muscle relaxants or anti-inflammatory medications. They may get imaging. Typically, we give back pain a chance to resolve for 4 to 6 weeks before we get advanced imaging like an MRI. The goals of physical therapy are to strengthen the core muscles, to reduce pain, to improve flexibility, to improve posture, to restore normal function. And I think the most important thing that you can learn from physical therapy are what you can do next time. So education is really a key part of physical therapy. I think knowing what to do the next time, if you can remember some of those exercises that helped you, because it's usually not a once in a lifetime event. And having the means to help yourself when this occurs is so important. So, prevention really is the most important thing. So have a good posture, strengthen your core muscles, stretch before you work out, practice good ergonomics at work, wear comfortable shoes, use proper body mechanics, try to maintain a normal body weight, maintain proper nutrition for bone health, and quit smoking. And why do we care about smoking as it relates to the spine? The spine does not have, when we talk about cartilage and the discs, they don't have the best blood supply. So when you smoke, it causes vasoconstriction or temporary narrowing of your blood vessels. And this further decreases blood flow to an area, the discs and the cartilage in the spine, which already don't have a great blood supply. So when you quit smoking, it's that much more protective. So in terms of what I do as an interventional pain physician, I do injections and procedures throughout the spine, including epidural steroid injections, nerve blocks, radiofrequency ablation procedures, joint injections, both into the facet joints, the sacroiliac joints. I do sympathetic nerve blocks for specific types of pain. And I sometimes prescribe medications to help with nerve pain related to nerve root irritation. So those medications include things like anti-seizure medications and antidepressants. And the reason we use those medications to treat nerve pain is that when you look at the neurotransmitters that are involved in brain transmission, they're actually the same neurotransmitters that are involved in managing seizures and managing depression. So the compounds, the neurotransmitters that we're talking about a neurotransmitter called GABA. So you may have heard of gabapentin, or Lyrica also works on the same receptors. And then we use antidepressants because they work on dopamine, norepinephrine, serotonin. These neurotransmitters are involved in the transmission of pain signals. So we can use these medications to treat pain, and they are highly effective. So in terms of epidural steroid injections, the idea is that we are injecting an anti-inflammatory medicine or a steroid into an area where there's inflammation, and we can thereby reduce pain. So this is, again, a view of the spine. So this is the spinal cord. There's a nerve root coming off to the left and to the right. And then the spinal cord is housed in a few protective layers, the outer whichmost is called the dura. So when we say epidural, we mean the space that's outside of the dura, which is why it's called epi, meaning outside, epidural space. So it's actually the 360-degree space that surrounds the spinal canal, and the spinal nerve roots course through that epidural space. So by doing an injection directly into the epidural space, I can inject anti-inflammatory medicine in a very targeted fashion where there is inflammation or narrowing around a spinal nerve root to try and relieve pain. So there's two approaches to an epidural steroid injection. One is what we call an interlaminar approach, which is where I put a needle in from this direction into the epidural space from the back, basically. The other approach is actually to come in from the side, to come in through this opening, which is called a foramen, and that's called a transforaminal epidural steroid injection. So a lot of times patients will ask me, what is the difference between an epidural steroid injection and a labor epidural that women get for labor pain? So the difference is, number one, there's no steroid given to women who are laboring. And number two, with laboring women, what we do is we actually place this catheter in. So we do an epidural, we place a needle in the epidural space, we place a catheter through it, and then we remove the needle and we leave that catheter in. So laboring women will have this catheter left in, and we infuse a combination of local anesthetics and an opioid pain medication to blunt the pains of labor. So this is what X-ray, what fluoroscopic imaging looks like. So this is an interlaminar approach, or the posterior approach to the epidural space. And this is the approach where the needle has been placed in the foramen. And you can see there's some contrast here that's been injected. It's outlining the spinal nerve root. And there's also some contrast in the epidural space. So in terms of the evidence, there was a 2013 meta-analysis of 39 studies on lumbar transforaminal epidural steroid injections. One study showed a success rate of 60% for providing at least a 50% reduction in radicular pain, or pain that goes down the legs or arms, at between 7 days and 3.6 months. 2 studies followed patients for 6 months, and at the end, 60% of patients had at least 60% pain relief. And that was done in the setting of a disc herniation. in terms of an epidural steroid injection for spinal stenosis, one study showed 64% of patients were completely or somewhat better after transfemoral epidural steroid injection, and that they reported 50% reduction of pain in 75% of the patients. If in the event of foraminal stenosis, which is narrowing where the nerves exit the spinal canal, 2 studies showed that at 6 months, 54% of patients achieved at least a 50% reduction in pain. And I had mentioned other types of injections in the spine. So this is showing you a facet joint injection. So as I mentioned earlier, the facet joints are these joints between the inferior articular process and the superior articular process of the vertebral bodies, which are stacked on top of each other. So this is a true joint with a synovial fluid inside and a capsule on the outside. And if there is inflammation, injecting a steroid in there can alleviate the pain. And then this is the sacroiliac joint, and it's named because it is the joint between the sacrum, which is this portion of the spine, and the iliac and the iliacus, which is this bone. So sacroiliac joint here. Another way of treating facet joint mediated pain is actually to target the small nerves of the spine which supply sensation to the facet joints. Those are called medial branch sensory nerves. So you can see that there's one at each level. So here's a medial branch nerve, here's a medial branch nerve, here's a medial branch nerve. So what you can do is you can inject some local anesthetic, which is a numbing medicine, as a test. So it should last, let's say, 6 hours, and you have patients keep a pain diary in that time. And if their pain is significantly reduced over the course of those 6 hours, and they're able to, bend, twist, do more activities with significantly less pain, the next step would be to do this radiofrequency ablation procedure, which involves putting a needle alongside the nerve, as depicted here, and then placing an electrode through that needle. And then some current, some radiofrequency energy is sent through to the tip of that electrode, which causes the tissue molecules to vibrate, and that generates heat. So it's a heat lesion of these nerves. It's not a permanent procedure because the nerves will regenerate with time, but it takes a long time, about a year. Another modality I use to treat pain is what we call spinal cord stimulation. So this works by delivering small electrical pulses to the pain pathways, which are in the back of the spinal cord. And this helps to kind of modulate the pain signals as they travel up to the brain. It's not a new therapy. It was actually invented in the 1970s, but I think it remains, a not very well-known therapy. So we can you do this for multiple indications. So sometimes I do it for patients who've had surgery already in their necks or backs, but who unfortunately have developed scar tissue and continue to have pain down in their arms or down their legs. It's also indicated just for back pain and just for neck pain. Sometimes we do it for what we call neuropathic pain, which is pain stemming from some of the peripheral nerves, and that can be related to diabetes. It can be related to patients who've been exposed to chemicals in their lives, like chemotherapy, or it can be related to what we call complex regional pain syndrome, which is nerve damage, a nerve pain condition that can develop following even minor injuries, like a sprained wrist. You can develop complex regional pain syndrome, which is a neuropathic pain condition. So this is just showing you the principle of spinal cord stimulation. So these are the pain pathways in the back of the spinal canal. So you can affect the ascending, or the pathways that travel up to the brain, and you can also affect the descending pathways, so the inhibitory pathways, in a way that reduces pain at the targets. So this is just showing you some of the components. So this is the remote control. This is how a patient would turn it on and off. This is it's called an implanted pulse generator. It's basically a battery and the machine of the system. So the wires get placed in the posterior epidural space, and they get actually fed into here. And this can be controlled via the remote. So you can change the programming that this little pulse generator delivers to the posterior pain pathways. And there's a representative from each company. There are multiple companies that do this. Nevro is just one of them. And that's how we can try and treat pain using this. So typically, there's a 5 to 7 day trial where I do, just like an epidural steroid injection, I place a needle into the epidural space, put the wires through the epidural needle, take out the needle, just like I showed you with the pictures, explaining a labor epidural, and then I tape those wires to the skin. And you go home and you test it out for 5 to 7 days. And this is what it would look like. And if you have significant pain relief over those 5 to 7 days, then we take everything out and we schedule a time to actually put the device in permanently. So I already covered some of the indications, but basically nerve pain, whether or not you've had back surgery in the past, nerve pain stemming from nerve roots, like what I referred to as sciatica before, or radicular pain, whether that be in the neck or the lower back. And then I mentioned for nerve pain, and then in certain countries, it's approved for what we call ischemic pain. So meaning patients who have severe vascular disease, severe peripheral vascular disease, can have pain associated with that lack of blood flow to their extremities. Unfortunately, it's a little bit difficult to get that covered in our country. In Europe, they do it a lot, but it's not a covered indication in our country yet. Phantom limb pain, so patients who've had amputations can have something called phantom limb pain, and spinal cord stimulation is very effective for that. There's a condition that follows shingles called post-herpetic neuralgia, which is excruciating nerve pain, and we can use spinal cord stimulation to treat that. Arachnoiditis is a condition that is due to scarring of the spinal nerve roots before they've exited the spinal canal. So within the cerebrospinal fluid, so inside the canal, there's fluid called cerebrospinal fluid, and the nerve roots are there before they exit the canal. And if you have scarring and inflammation, that's what we refer to as arachnoiditis. And typically we see that the nerve roots are all clumped together. So in that instance, there's not much that can be done for that, meaning there's no surgery to go in and separate them and try and alleviate it. We'll just make the situation worse. I don't do epidural steroid injections because in theory that could make the arachnoiditis worse. So that's really a case where I would strongly recommend spinal cord stimulation. And then post-laminectomy syndrome. So post-laminectomy syndrome is pain after spine surgery, and that can be due to scar tissue. Again, you can't really go in there and clean out scar tissue because it just reforms. So that's also an indication for spinal cord stimulation. So red flag symptoms, I did touch on this a little bit, but if you have unexplained fever or weight loss, you're having, chills, night sweats, that is very concerning for a possible cancer or possible infection. If you have a history of immunosuppression, like for example, you have been taking, steroids chronically, and you're more vulnerable to infection. If you have a history of cancer, if you have a history of osteoporosis or prolonged steroid use, we worry about fracture. If you're over 70, we also worry about fracture. If you have a known history of IV drug abuse, we're very concerned about infection. And if you have progressive neurological deficits like weakness in the extremities, balance issues, and if the pain has persisted longer than 6 weeks, these are all what we consider red flag symptoms, and you should talk to your physician right away about this. So at Comprehensive Orthopaedics, we offer orthopedic spine surgery, interventional pain management, diagnostic imaging, and physical therapy. Thank you for your attention, and I look forward to meeting some of you soon.